Willis, and we're available for questions at the end of Dr. Willis's presentation.
Matthew, good morning, everyone. Al, if you could bring up my presentation, I'll ask you to advance slides if that's okay. I'm going to offer an update on our COVID-19 status. I'll start with the numbers, where we are generally in our course of the pandemic, and then offer some very brief updates on some of our key strategies and priorities for this week. Next slide, please. This is our cumulative case counts over time, and what this shows is that we're since the beginning of the pandemic in Marin, we've had 3,552 cases total, and the yellow and red lines at the bottom signify the number of hospitalizations and deaths, which remain at 153 hospitalizations, I believe, and 58 total deaths. Next, please. This is the summary of the total persons tested. We've tested over 63,000 people. And it's 123 total hospitalized with 58 deaths. And those who are currently in the hospital right now in Marin County, it's 13 with 10 members of our community and 3 San Quentin inmates. So with that number of 10 community patients, we remain at some of the lowest levels of hospitalizations we've had within the last 2 months. Next slide, please. When we talk about flattening the curve, that curve is the curve of the daily number of new cases. So this is that. COVID-19 cases per day in Marin County. We've switched the way we will be reporting this from the report date to the testing date. And it shouldn't change much, but it's an important distinction in terms of if we are seeing backlogs, as we've seen at the state, where there might be a delay in reporting and then bundles of cases coming in on a given day that might lead to what apparently might look like spikes like cases based on the report date. We're actually putting those back into where the test occurred that corresponds to that case, so that we're having a more accurate picture of the actual epidemiology in our county rather than describing issues with the way it's reported. So this is our total cases per day based on the date that the test was done. And it does show that there's been some flattening of our curve here with a peak in around July 12th. And we're seeing a reduction in new cases per day. That shaded area of red corresponds to where the state reporting system had some issues with regards to delays in getting cases to us. We are reconciling that. We're still in conversation with the state. Other counties are also seeing, while the differences between local reporting and state reporting are narrowing, which is reassuring, they're not fully reconciled. And so we are still offering that as a caveat and hope to have that fully resolved by next week. Next, please. This is a number that's important to us because this is what the state uses for its designation for the counties on the monitoring list, which is the 14-day case rate per 100,000 residents. Any county with more than 100 cases of that 14-day case rate per 100,000 residents is on the monitoring list. We are, by our measurements in Marin, we see ourselves as having about 171 cases. The state lists us now as having 140 cases. And that's an example of that difference that I described between local reporting and state-based reporting. The accurate number is likely to be within that range. And this is a difference that we're seeing in other counties as well. And again, working with the state to determine why there might be a discrepancy there. Next, please. This is the number of hospitalizations in Marin County and shows that, in agreement with what we saw in terms of changes in our case rates, we are seeing improvements in our hospitalization rates since that peak in earlier July. Currently 13 in the hospital and 4 in intensive care. Next, please. This is modeling. I'll start to show more modeling now that we have more confidence in the modeling initiatives that are gathering together aggregate sum of models from a variety of different modeling initiatives across the nation. This is CalCat. CalCat is a service provided by California Department of Public Health that pulls together models, sort of the dominant and best models from across the nation, and then sums them. And what we see on that ensemble, that dark blue line there on the bottom, that's the ensemble projection. And that is I think if we want to look at any modeling, that's probably the most important or accurate indicator for us to look to. And what this shows is our modeled anticipated number of hospitalizations forecast between now and mid-September. And what it shows is that while we currently have 13 people in the hospital, the modelers would forecast that we should have about an average of 17 per day in the hospital between now and mid-September, with a relatively stable incidence, which is reassuring. Next, please. This is our demographic profile. Again, what this shows is the proportion of cases by age. On the left, those columns, on the far left is the proportional distribution by age. We have different age groups across our community at baseline, and then shows how those relate to COVID-19 cases, hospitalizations, and deaths. The most important thing here, I think, is the recognition that with increasing age, there is increasing risk, where we see deaths being 95% of our deaths among people age 65 or greater, and 70% of our deaths in people age 80 or greater. On the right, no meaningful difference between by gender in our cases. Next, please. This is, a key feature of our experience with the epidemic in Marin County. This is our race ethnicity profile, showing that on the far left, what our baseline proportion is of different race ethnicity within the county. 16% Hispanic, Latino, notably 75% of our cases. Next, please. Now we'll get into briefly some of our key actions and priorities for this week. Shelter in place order. So we are on the county monitoring list. We are among that, between 35 and 40 counties across the state who have more than 100 cases per 100,000 residents over the past 2 weeks. That sets limits by the state of what we can and can't open. On August 24th, we will move forward with opening hotels and short-term rentals if our 14-day case rate remains below 200 cases per 100,000 when we look on this coming Friday. Given that the two numbers that I offered, the state number of 140, ours of 170, are both beneath 200, and there's only 3 more days of observation before we would check on Friday. It's very unlikely that we would be above that number, especially since it's really based on the state's number in terms of our official position regarding the monitoring list, and that number is the lower of the two. So it's likely that we will be moving forward with this decision, but again, we will have to wait till Friday to look. Importantly, short-term rentals, when we do take that step, will be limited to the household unit, and there will be no parties or gatherings. If I have any concern about opening up to short-term rentals, it is the possibility that it's an invitation for gatherings indoors of people outside of their social bubbles, outside of their households, and that could fuel transmission. So after that step is taken, we would have full alignment with the state order for counties on the monitoring list. Currently, we can only do things that the state would allow, given our status on the monitoring list. The only thing that's remaining that we haven't yet taken is this step towards opening hotels and short-term rentals. So after that step is taken, we would be in alignment with any other county on the monitoring list. Next, please. For schools, we talked about this last week. Because our 14-day case rates are between 100 and 200, we are able to move forward only with TK through 6 schools with the approval of a waiver from the local public health officer. So on August 14th, Marin County Office of Education and Marin County Public Health, last Friday, we issued the waiver application. We completed it and distributed it to the school community. It is a rolling application process. We will consider waivers as they come in. On August 21st, this coming Friday, we will begin review of the submitted applications on the 28th. We'll send any locally approved applications to California Department of Public Health for their approval. And the earliest any schools would open would be September 8th. And just to, stepping back, remembering that the best way for us to get children back into school safely is to reduce overall community transmission. So that's a role we all have in getting children back into the schools where we think is the most important place for them to be during the school year. Next, please. Another key aspect of our strategy, based on some of the data that I shared with you, so 75% of our cases are in people who identify as Hispanic or Latino, despite only being 16% of our population. That particular dynamic is actually concentrated primarily in one neighborhood, although it's true in other regions across the county. The Canal area of San Rafael, which has a high concentration of our essential workforce, Spanish-speaking immigrant community, has had, borne the brunt of the majority of the cases that we're seeing in the community. And so we've worked with some of our key community partners listed here: Marin Health and Human Services, San Rafael, City of San Rafael, Kaiser Permanente, Canal Alliance, Marin Community Clinics, and Marin Health, starting in mid-June and mid-July to develop a coordinated and integrated community-wide strategy with the goals of improving coordination of activities across partners, with integrating our processes, increasing community ownership, making sure that diverse community stakeholders and influencers are actually empowered and enabled to describe the problems, to actually influence the strategies, to better understand the barriers and gaps that are being experienced within the community, and that we are enhancing our communication, really focusing on the audience itself and in the canal and the diversity within the canal. That neighborhood itself has a lot of diversity that is best sort of determined by conversations with community members themselves. And our orientation is towards health education and behavior change through communication. Next, please. There are 7 teams working on the Canal Outbreak Response Plan. The teams meet weekly to address gaps. They are co-led by a community-based leader, as well as a member of the partner agencies I listed. One team is dedicated to epidemiology, just making sure we're data-driven, providing canal-specific data to inform our activities. Another team is dedicated to outreach, engaging community-based organizations, educators, schools, faith-based organizations to amplify our messages and activities. A team dedicated to health education, bringing health educators from Kaiser and other healthcare partners to develop educational materials and train promotores, train trusted voices from within that community to offer those messages. Another team dedicated to communication strategies, especially focusing on media and influencers. A team dedicated to business and commerce, developing partnerships to support safe business practices. Another team dedicated to testing, to drive canal specific enhanced testing, recognizing that barriers to testing have been an important issue for us. And then finally, a team dedicated to isolation and quarantine to coordinate and increase opportunities for safe isolation and quarantine for everyone who is diagnosed or those who might have been exposed. Next slide, please. So in order to have clear strategies, we need to have a really clear understanding of what it is, what problem we're trying to solve. To answer that, we really needed to have a better sense of the voices of the community itself, to describe the challenges and barriers they're experiencing. And so we, through this effort, performed a community survey. And I'm just offering some of the key findings here. Majority respondents did believe that COVID-19 was a serious threat for their family, but had trouble isolating or quarantining at home, or thought they would, or to travel to Nevada, where the primary option for isolation quarantine was, because it was too far. So the recommendation was to identify a hotel in the Canal to serve for quarantine isolation. And that has been secured, and that's one of the successes of this effort has been relocating a hotel. 1 in 4 respondents got at least one COVID-19 fact wrong, where there was a process of soliciting what people's beliefs were about COVID-19 and how it might be treated or how it might be caused. And the recommendation from that was to develop a myth versus facts infographic, which I'll share with you, and then provide COVID-19 prevention messages at every encounter. The next important, I think, finding from that survey was that barriers to testing were identified a variety of barriers to testing. 18% feared missing work if they were tested positive. 15% feared that their immigration status might be in jeopardy, or that there might be concerns relating to immigration status if they were to be tested and placed on a list. 30% feared losing their housing if they were known to be positive, and 28% did not believe that they could afford testing. And so the recommendation there was to broadly disseminate tailored testing information across a variety of channels and influencers, really through locally trustworthy voices, to address each of those concerns specifically. Next. These are some of the initial successes of the Canal outbreak response. Increased Spanish language media engagement. We've now secured Canal-specific radio outreach across multiple radio programs on a weekly basis. As I mentioned, a hotel has been secured in the Canal for quarantine and isolation, walking distance of the housing. Improved testing access. We have testing access now 6 days per week, again in walking distance at Marin Community Clinics. And the testing turnaround has improved, partly because the laboratory that Marin Community Clinics is using, which is Quest, has had shorter turnarounds, as well as supplementing that with 2-day turnaround testing that's available through public health. They're also performing antibody testing to determine what the baseline prevalence of infection may have been in that community, and then also performing, in some cases, rapid testing for people who are having symptoms on site. 36% of Canal residents have been tested thus far, and our goal is to test half of the Canal residents before September. The Why I Mask campaign has distributed at least 600 posters in key areas, including buses. I'll share some of those graphics with you. We've hired contact tracers from within the community to make sure that those conversations around all those sensitivities that I highlighted are being navigated with a trusted partner from within that community who can have a more informed peer-to-peer communication. A site-specific protection plan that every business needs to develop has been developed for, support for that has been developed through a training video for Canal businesses. Canal business owners also not all are primary English speakers, and we need to make sure that we're able to offer them the support they need to have that site-specific protection plan be completed and be as thorough as it can be. Marin Strong campaign is an exciting initiative with Equipe, which is a Canal-owned and operated company that makes cloth masks. The County of Marin, City of Santa Fe, and Kaiser have provided seed funds for Equipe to make cloth masks in the Canal, and they are distributed for free to Canal residents. A safe recreation campaign has also been initiated in coordination with Santa Fe Recreation to promote safe recreation at Picklewood Park. Next, please. So these are just some of the infographics that were developed as a result of the community survey. It's for our partners to use in outreach and education. It's really a focus on visual communication, recognizing that because of the diversity of language, not only Spanish, but other indigenous languages from some of the some of our immigrants from Central America, really making sure that we're not making assumptions about what people can take in terms of the written language, whether it's Spanish or English, but really focusing on images and as a result of that community survey. And these are some of the images that have been developed for the community. Next, please. This is the Canal Alliance, the facts versus myths campaign. For example, upper left there, chlorine dioxide is an industrial bleach. You know, the rumor, it's not just the president who cited that as potentially a treatment. Obviously, not a treatment for COVID-19. Bleach is toxic and potentially deadly. And so there's an infographic in English and Spanish that just makes that clear. Other rumors to address as well on the top there. And then showing on the bottom some of the culturally informed imagery that the Canal Alliance has promoted around a rich history and culture and really trying to come together to promote COVID-19 from affecting that community. Next slide, please. These are images of, there's 27 images like this of members of that community who have been photographed wearing masks properly to normalize mask use. And we recognize some of these faces ourselves. And this campaign has been used in posters and on buses throughout the Canal area. Next, I think that concludes my presentation. I'm open for questions now, or we can from the board or the community. Thank you.
Matthew, do you have much more on your administrator's report? I think I'd have you finish or anything under your administrator's report and then take board questions before we go to public comment.
All right, supervisors, the only thing I wanted to acknowledge the pressures that our working families are under with the remote school coming up. And the assistant county administrator held a listening brainstorming session with working parents of the county. They provided your board and my staff a letter, and I just want to let you know that we are working with HR and the departments to follow up on that letter and making sure that we're doing everything we can to accommodate our working parents. And there are some things that we know we can do, such as flex scheduling, telework we've done extensively, using available leave balances when appropriate. So I just want to let you know we are following up on that, and we'll come back if there are other specific actions we need to take.
Great, that's excellent. And then did Benita want to bring anything in from Health and Human Services? More generally right now? Related to COVID, was she going to speak to? There she is. Hi, Benita.
Good morning. Yes, good morning, President Rice. I don't have anything to add at this time. I will have comments if there are any thing to respond to from the public.
All right. Dr. Willis, a great report as always. And I thank Supervisor Sears for prompting the more detailed and sort of framing on the work that's going on in the canal, not just through your report, Dr. Willis, but also on the website. And I think we've probably all seen that. So do we have questions from board members for anything under the administrator's report? Judy. You need to, there you go. Thank you.
Is there a time that businesses that are partially open now and eager to open fully can count on us looking at their numbers and deciding can they move up? Is it every 2 weeks? Is it that's the question.
Great. Yes, well, that will be determined. Right now, our status on the state monitoring list limits what we can and can't open. And so we are, if we take the action that we anticipate to take with regards to hotels and short-term rentals, we will be at the limit of what we can do. And we won't be able to open anything further than that. Until our case counts are less than, our 2-week case counts is less than 100. We're closer to 150 now. So unless the state changes the rule, we would have to wait that interval of time it will take us to reduce to less than 100. Right now, it seems like we're moving in the right direction. I've shared some modeling that shows that we are improving on a weekly basis, and that's really hopeful. It will still take, and this is where we don't have a crystal ball, but it will still take weeks, I anticipate, to get to that level. And this will be an important objective for all of us, is to do everything we can to get those rates down to less than 100, so that we can make that decision to reopen, and would celebrate the ability to reopen safely when we can.
Thank you.
Supervisor Connolly.
Thank you. Good morning, everyone, and thank you again, Dr. Willis. In terms of tracking our progress vis-a-vis the state watch list, we are getting some questions from constituents on whether we can change our progress page online to align with the watch list parameters more clearly, namely number of current cases per 100,000 and percent positivity.
Yes, the place to look now on the website for the number of cases per 100,000 is on the indicators. So if anyone goes to the data, Marin HHS marinhhs.coronavirus.org, and then the data page, and then there's an indicators subset. That's where you find the number of cases per 100,000. The percent positivity, we need to, the state indicators of what determines whether a county is on the monitoring list have been shifting. So one of the reasons that we've held back on actually having that be the dashboard that we use locally is that hasn't been finalized yet. But we know for sure that the number of cases per 100,000 is the most important indicator for us, and is the one that we are furthest from achieving, and will very likely be the rate limiting factor for us in moving forward. So we can certainly bring that number more prominently up onto the website so that people can find that number more easily. But also once we have a really clear indication of specifically what the state is using for the we'll also offer those for the public to see.
Thanks. And on testing, you briefly touched on the turnaround time. A constituent recently got in touch who got tested through Quest in mid-July. It was a 7-day turnaround. It sounds like those turnaround times have changed subsequently. If you can kind of go over those and where we stand right now.
Yeah, I mean, I'm optimistically, I think we're out of the worst of the turnaround. I mean, there was an interval there where for significant portion across the state of the private labs, especially, turnarounds were 7 to 10 days, including Quest Diagnostics, which may be doing the majority of tests, or the lab that has the highest number of tests. Right now for Quest, we're looking at about 4-day turnarounds, and that's, we use Quest for the LHI site, which is one of our sites in the Canal that does about 130 tests a day, and Marin County clinics. The Federal Qualified Health Centers use Quest because that's Partnership Health Plan. Our Medi-Cal provider uses Quest Diagnostics. That's been reduced because they do now, they have a new method where they're doing batch testing. So they'll bring in a certain number, like 10 tests, and test them all at once. And if any one of them are positive, then they'll test each one individually. But if they're all negative, we can move on to the next batch of 10. And so that's one method that has actually allowed them to have higher throughput, which has reduced turnarounds. And then turnaround times for color labs that we've been using at our point of testing site, about 300 tests a day, are reliably 24 to 36 hours. Kaiser turnarounds have gotten a lot better as well. Our public health lab, the regional laboratory, and the state laboratory have about 2-day turnarounds. So I would say the average turnaround for testing in Marin County has reduced significantly over the past, say, 2 weeks.
So do total testing numbers reflect the number of unique individuals who have been tested, or could it include individuals who have been tested multiple times?
Yeah, we've been counting tests. When I say 60,000 plus tests, that's the number of tests that have been performed. And it may now, especially now that we're sort of further in, months in, those individuals who have been tested twice have not been removed from that testing number. So it reflects the total number of tests. So that's a distinction that I should make clearer, which is that's the number of tests, and we will find a way to deduplicate, those numbers of individuals versus the number of tests, as some portion of people seek testing a second and third time. They are being counted.
So that work will occur then, that breakout.
Right. I mean, both are important. We need to know the number of tests. Our testing goals are related to testing itself. Testing capacity is testing capacity. We need to make sure that even if you need to test the second time or the third time, you still, for legitimate reasons, we want to make sure that capacity is available. So we need to measure the total number of tests performed, and I'll continue to report that. But then we could be more clear in terms of the number of individuals that represents. Importantly, our number of cases is individual cases. So when I say COVID-19 positive cases, those are individual. So if someone tests positive twice, they will not be counted as a case twice. They will be counted as a case once.
Great. And then turning to the Canal, appreciated hearing about the testing rate in the Canal, some of the barriers that are being faced in terms of getting tests there, and the strategies around that, the goals. Joining in the appreciation to Supervisor Sears for bringing up the Canal focused webpage. You indicated that there is now a hotel available and in operation for people in the Canal to quarantine. The question is, how is word getting out that financial assistance is available for people who test positive to stay home from work or to have that quarantine option available? And are the details shared through contact tracers or more broadly?
Yeah, I mean, one of the advantages of having this coordinated response infrastructure and working with a variety of community partners is that any message that's important to get out there has way more channels to actually get into people's awareness. So there's a variety of different ways that people are informed about the supports that are available. One is through the testing itself. So when there's, at the point of testing, we want to make sure that people are aware that if they test positive, those supports are available and there's information that's offered at the testing sites. When we're inviting people to test through the networks, through the promotores and others, that message is paired, because we know that if there's a fear of not having income if they test positive because they will not be able to work, it's really important to match that invitation to test with reassurance that there would be support if they test positive. And then when we do the contact tracing, if we identify that someone is employed and are advising them to stay out of that place of employment while they're positive for at least 10 days, which is the recommendation, immediately tying them to case support for that income support. So there's a warm handoff to the case managers from the contact tracers to tie them into those income resources.
Thanks.
Supervisor Sears.
Thank you, and good morning, Matt. Thank you for that good presentation. Just a couple of questions. Do we currently have sufficient motel capacity for everyone who should appropriately be quarantining?
No. You know, I mean, if the question is, do we have housing for every person who tests positive for whom they're not able to safely isolate from others in their household, I think that's a barrier to our epidemic response across the state. The number of positive individuals who live in housing conditions where the risk of transmission within the household is elevated far exceeds the stock of available housing, and it's a challenge to get. I mean, the conversation with a hotel owner to say, you know, we would. Are you able to make rooms available for COVID positive people in your hotel is a challenging conversation. You know, it's a business decision, and obviously not everyone is eager to make that business decision. And so one of our strategies is to do everything we can to identify housing resources, working with our own direct relationships with hotel owners, motel owners, et cetera, but also working with our community partners. This is one of the strategies that we're using our Canal Outbreak Response Plan and the diversity of partners to help us identify more opportunities for safely isolating people. Right now, one hotel with 22 rooms in the Canal is excellent, but if it's a 10-day rollover, that's 60 people over a period of a month, which is a lot better than none, but doesn't match the demand. There's another hotel in Novato that has been used, and then there's another resource in Southern Marin. Those are overflow hotels. The other important barrier there to recognize is that we had empty rooms, even though we had that resource, based on the fact that there was individuals who were afraid to isolate. So it's one thing to identify the sort of the epidemiologic value of isolating. It's another thing for someone who's positive to actually make a decision to take us up on that offer, to offer free housing. Because of concerns, we learned that many individuals are breadwinners for their household, essential workers who may have been infected in that setting at work or just in the course of their life out in the community working every day, maybe bringing it back into the household. Obviously, that's the transmission we're trying to prevent, but they may say that I'm not able to leave my children or leave others at the household that I care for. So it ends up being a lot more complicated to try and actually operationalize and execute that goal of isolation, both for behavior reasons and then for supply reasons of housing.
You bet. Thank you for that very good response. And I wondered if you also might want to say something about flu season and flu shots.
I would like, thank you. Yes, I would. So this year more than ever, we need to make sure that we're protecting ourselves. COVID-19 has taught us a lot about how serious viral respiratory illnesses can be. And we know that if we're having co-infection between both COVID-19 and influenza, the risk for mortality is much higher. And so this is a year where we all need to be doing our part to protect ourselves against influenza. The good news is that while we don't have a vaccine for COVID-19 yet, we do for influenza. And it's looking like the influenza season thus far has been relatively mild. We want to protect ourselves as much as we can by getting that flu shot. And they're now available, which is great. This is early for flu shots to be available, but this is the time. CVS now has flu shots, and some of the other pharmacies are getting them, and some of our healthcare providers also have them in stock. So that's the basic message: is get your flu shot, and Health and Human Services will be developing. We don't have our supply of vaccine yet, but we'll be developing our distribution plan once we have our vaccine.
Great, thank you.
Supervisor Rodoni, any questions?
Yes, thank you, President Rice. Dr. Willis, I was wondering if you could comment on, and thank you for the presentation, and the outreach looks terrific. Really pleased to see that. I'm wondering if you had any data or any surveys that have been done that indicate the outreach might be working, or plan to do something to see if your outreach is being effective. And that may be someone else's question, so feel free to pass it on.
Well, yeah, I mean, I think the ultimate test of whether the outreach is working is case counts. You know, I mean, our goal is to flatten the curve in the canal. So there's there's kind of approximate metrics we could develop to see, more queries about, did you find this outreach helpful? But ultimately, the reason we're doing all of this is to prevent illness and death, and we're tracking those numbers very, very closely. Our goal is to flatten the curve in the canal. We're going to be looking in mid-September to see whether or not we've actually reduced the number of cases through the combined efforts of everything that we're trying to do. But we don't have a plan now to sort of resurvey the community about the effectiveness of the outreach itself, because there's some obviously survey fatigue that can set in. But I think hopefully we've developed, I think our goal is that we've developed open communication channels where we can revise and refine the outreach strategies based on what's landing when one of our promotores, as part of the outreach plan, is reaching out to a family to communicate and having that conversation. Things may or may not land the way they had intended to. And our hope is that we've developed feedback loops where we're able to modify and act on that in real time.
And then just talking about short-term rentals, you had a couple bullets that followed the potential opening for short-term rentals, referring to who could rent them and no gatherings and parties. I'm just concerned that if those are in fact requirements, that we don't have the enforcement in place to follow up on it. And I think that's a bad message to be sending. So I would recommend you look at those and see if they should just be recommendations, so that we don't put our enforcement people or our complaint people in a position where they're going to get a lot of complaints, and where if we're unable to enforce them, then maybe they just shouldn't be set in stone. They should be recommendations. So I would ask you to take another look at that, because short-term rentals have generated a lot of complaints, and people's expectation about short-term rentals have been very, very high. And in fact, most of the complaints probably haven't been valid given the health order, because people have been having people sign waivers that they're essential workers or whatever. Anyway, so just take a look at that. And I think being clear on that, and if you intend it to be a requirement, then we need to confirm with the enforcement people that they actually can carry through and make that happen. Lastly, and this may be Benita's question or not, I'm not sure. There's been a couple inquiries to my office about the flu season shot rollout, and with HHS being so busy with their resources dealing with the pandemic and everything else, and adding on the heat wave, will the programs be similar in terms of how they'll roll out the opportunities to get flu shots in our community this year?
Thank you, Supervisor. I think Dr. Willis can add to this, but this will be my first flu season in Marin County, and it's my understanding that we, as a county, in terms of our distribution of the flu shot, is limited, and that we really depend on our partners, our healthcare partners, to do the majority of the flu distribution, including our federally qualified health centers, our hospitals, our physicians' offices are the ones who distribute the majority of the flu shot in Marin County. However, as Dr. Willis mentioned, we will provide flu shot to county employees and others in the community that don't have access to resources. And please correct me, Dr. Willis, if I'm not correct.
No, you're right. About 95% at least of the flu shots administered in the county are not county shots. They're healthcare providers. We support our federally qualified health centers and their acquisition of flu shots. So we are sort of a pass-through. We get it from the state and distribute it to our community clinics that serve our low-income communities. But they're doing it through their pediatricians and their internal medicine docs at the clinic level. A lot of the shots are happening through the pharmacies. About half our residents are insured by Kaiser, and there's a robust effort through Kaiser. I've already gotten my reminders I need to get my shot. But we do get about 3,000 doses that we reserve for people who fall through all those other cracks, which some of our homeless residents and others. Some schools, we've been doing flu vaccines in schools. I think that's the biggest change for us this year, is that we can't rely on school-based vaccinations for kids while they're in classroom. And so we're having to find an alternative strategy to make sure that we're reaching those children that we were able to vaccinate in low-income school communities. And that's going to be through partnership with the clinics, Marin community clinics in particular.
Thank you.
Right.